Well, welcome everyone. My name is Nelly Araujo and I am from the Royal Society for Public Health. I'm the project manager for Making Every Contact Count for Mental Health project. And I'll be here facilitating this session, which we call Open House event. And here with me, I have Dawn Mitchell, who is our lead trainer developer, who's going to be doing a tester session about the training program. We'd like to keep the session as interactive as possible, so keep your cameras on and be ready to have input. If you have any questions, use the chat box. We will monitor them. I will stop just before the end of my presentation to check any questions. And at the end, we'll have a 10 minutes slot to have some conversations as well with you about what we just presented. The aims of the sessions to provide you with key information about the project, to give you a taster of the Making Every Contact Count mental health training program, and to answer any questions you may have. First of all, what's Making Every Contact Count for mental health? Many of you may know that the MECC approach aims to use the millions of day-to-day interactions that healthcare and the wider workforce have with individuals to actively engage in conversations about making positive changes for health and well-being. Those discussions are often called very brief interventions. They typically last between 30 seconds to 3 minutes. And they're just very short, purposeful conversations that provide an individual with information and the opportunity to access support. The Making Every Contact Count approach has been very successfully used to support behavior change in areas like smoking, alcohol, weight management, and physical activity. And there's loads of evidence that that there is a change in individuals that benefit from this approach. By contrast, efforts to implement Making Every Contact Count to improve mental health and well-being have not progressed so quickly, and so there's a high degree of coordination that needs to be achieved. To address this gap, Health Education England commissioned the Royal Society for Public Health to upskill the non-specialist workforce in primary and community care settings across the north of England by supplying high-quality evidence-based training that develops knowledge, skills, and confidence to integrate mental health and well-being messages in everyday interactions. And just to give you a quick overview about the Royal Society for Public Health, we are a charity that's been going around for over 100 years. We are an independent public health education charity, and we specialize in the development and delivery of education pathways and training for the wider public health workforce. And that is very wide-ranging. We work with people in the health protection arena, for instance, with food safety qualifications and training, and with the health improvement workforce as well. And the Making Every Contact Count is an example of that work. This is a project that is in its second phase. The first phase was from March 2020 to June 2022, just before the pandemic. We had started mapping out what we wanted to do with Making Every Contact Count. And we then went on to develop a training program that could be delivered face-to-face or online, or both. That was implemented as a pilot across all the ICSs in the north of England until June 2022. So we have just completed the first phase, and we are just starting the second phase with yourselves. But it's going to be heading first in the Northwest. And just to share with you a few of the outputs that we had during the first phase. We had an evidence-based co-produced training program which you will have a taster of at this session. We upskilled 12 local lead trainers and 100 trainers from 83 organizations in primary and community care and support services. 67% of those trainers delivered to at least 1,086 end users in the front line by June 2022, but we know there's still more training going on. And those settings include dental practices, GP practices, social prescribing, community pharmacy. And in addition, we did an adaptation of the core training program to be delivered in cancer care settings. And we're also working on doing another one for stroke care pathways. And we also created an additional module on making every contact count for menopause and the links between the menopause and mental health. And this is just to give you a bit of flavor of who was benefited with the first phase of the project. The training, as I said, was cascaded across all 7 ICSs in the north of England. The highest uptake was in North Cumbria and the North East with 25% of the training, followed by Greater Manchester, Cheshire Merseyside, and Humber and Cosvale with 14% of the training. As you see, 20% of the training was in dental practices, and followed by health and social care, community health promotion as well. We had a good uptake from social prescribing, as well as public health specialists and many others. The evaluation has just released a few days ago, and it was an independent process led by behavioral scientists, Professor Lucy Brown-Davis and Professor Joe Hart. Some of you may be familiar with some of their work. The evaluation framework for this project was based on the COMBI model, which is a combination of about 25 behavioral change theories and research. And they used a mixed methods to evaluate outcome and process for the project. The exercise included participation of about 450 participants, and data was collected through questionnaires, pre and post, and follow-up as well after the training program, interviews and observations, and there was a few focus groups as well. To give you a bit of a flavor of the data, we are here presenting in the box plot on the right, sorry, what happened before the training program and at follow-up in terms of the number of conversations and referrals that participants were having with people they saw in the previous weeks, in the previous 2 weeks to the training program. So we asked people how many people that you see during the last 2 weeks could have benefited from a health conversation and had it with you. And as you see in the first box here, which has the medium in the middle, it was about 60%. And after the training program, people reported that all the people that they saw that could have benefited from a mental health conversation had it with them. In terms of referrals, you see in the 2 boxes on the right that referrals were already low, but there was an increase in the follow-up, and we saw this as appropriate because not everyone needs a referral after having a mental health conversation. Nevertheless, it was really encouraging to see that the number of referrals had also increased. And just to give you a quick overview of the findings and outcomes of the project, the evaluators found statistically significant increases in the participants' capabilities, opportunities, motivations to have mental health conversations with people. and to refer people to further support. There was also statistically significant increases in the number of conversations about mental health and well-being, which participants were having compared to before the training. 3/4 of the participants reported avoiding using stigmatizing language, signposting, and asking open questions, listening reflectively, and asking people twice if they were okay, and responding empathically. And it is estimated that the program could have influenced over 13,000 interactions every 2 weeks. Now, the project offer, as it stands for the second phase, is offering these ICS, the upskilling of 2 further lead trainers and 14 trainers from primary and community care organizations in Cheshire and Merseyside. And depending on the demand, we can extend this offer to more people. Other statutory services like local authorities and third sector organizations with link to NHS services are welcome to apply. We are recruiting also organizations interested in accessing the end user training. So if you don't have capacity or capability to provide or nominate a trainer or a lead trainer, but you want to access the end user training, please come forward as well, because we can match you with some of the trainers that we have already in the pool of trainers that were upskilled in the first phase that can deliver that training. We offer trainers and lead trainers with RSPH membership. We are also a membership organization, and as part of our scheme, we provide various forms of professional development opportunities, like webinars. We provide access to peer-reviewed journals. There's also opportunities for training as well. We have a training hub, which has many e-learning programs as well as live training programs. There's also ongoing subject-related professional development opportunities through webinars and refresher sessions that we provide. Our training is accredited, and we provide CPD points, both lead trainers and also the end users for their attendance to the training program. And we provide access to a hub of materials, and I will give you a bit of a demo at the end of Dawn's presentation, just so you get a flavour for what is there already. The expectations for trainers and lead trainers. The time commitment for lead trainers is an equivalent of 8.5 days, and for trainers is 4.5 days from September 2022 to February 2023. For lead trainers, this includes the attendance to the 2-day train-the-trainer session, which is delivered online. Some help with recruitment, if they would like to help us to recruit other trainers or organizations. Delivering the 2-day train-the-trainer session themselves to other people in the region, and supporting the trainers in the area and the participation on evaluation activities. Now, the support that we will ask them to provide to trainers would be around giving one-to-one sessions to trainers before they deliver the training, their first training session, and we provide guidance as to how that is going to be delivered. For trainers, it's, as I said, 4.5 days, and this includes attendance to a 2-day training session, the recruitment of a minimum of 12 attendees from primary and community care settings, delivering the training session, which can be delivered in between 7 to 9 tutor-led learning hour session, and the participation and evaluation activities. And now trainers can deliver the training program to settings beyond primary and community care, but we would ask them that for their first training session, they ring fence 12 spaces for staff in primary and community care settings. There is more detailed overview in a expressions of interest call that I will post in the chat so you can have a look. But we'll also send it on an email after this event. Now I'm going to hand over to Dawn, but if there are any questions, I can answer.
There's a couple in the chat, Nelly. So Denise has asked, how did you monitor referrals?
Okay, so referrals are self-reported by the trainer or by the end user. And it was data that we collected on the pre, post and follow-up surveys and that were sent to them. There was also, we carried out, well, the evaluators carried out 30 interviews with key stakeholders, trainers, and end users. And it was also a way of contrasting the data. And it was very, it all married very well. So we can say with confidence that the self-reporting of the referrals was fairly fairly accurate. But you can read a little bit more about this in the evaluation report, which we'll also send after this session. And then how can we access Training Hub? Is this on your website? Okay, so the Training Hub is going to be accessed by trainers and lead trainers. And so when they sign up, we will provide them with access to them. And I'll show you a little bit more about how that works in a little while. I think those are the only two that I have.
I think so, yeah.
Excellent. So I'll hand over to you.
Thanks, Nelly. Hi, everyone. My name's Dawn Mitchell, and I was one of the lead trainer developers on this programme. I also worked, the other lead trainer was Karen Thomas, and so I led on the mental health content for the training, and Karen is just had a wealth of experience around making every contact count. So we joined forces on this. So do you want to pop us onto the first slide, Nelly? Okay, so we have developed 3 modules for the MECC for mental health training, and I'm just going to give you a bit of a flavour of each module. So there's 3 elements to each module. So there's the face-to-face or online training, and that is accompanied by a journal, which you can see on this slide. So each module has a learning journal that you fill in as an end user, that you fill in as you go through the training. And then there's also been the development of a 30-minute digital learning package for each module. And those, I'm sure we can share the links for those. So those were the elements of the training that we developed. And obviously we then had the train the trainer angle to fulfill as well. So let's have a look through each of the modules. I'll try and give you a little bit of a flavour. So module 1 is more focused on the kind of mental health awareness raising, so key messages around mental health and well-being. Language we kind of focus on throughout, so sometimes mental health is used interchangeably when we might actually be speaking specifically about mental illness, so just have a think about the different language that we use. And obviously looking at the MECC approach and exploring how we can apply MECC for mental health in our health and care settings. Next slide, Nelly. Brilliant. Okay, so a little bit of content from module 1. So one of the first things that we look through is the dual axes continuum for mental health. So we look at some little case studies. We think about what it means to be in these different areas of the mental health continuum. We talk about how people naturally, as part of life, move around this continuum, and then we think about what does mental illness look like in terms of our continuum of mental health and well-being as well. We have a think about the stress container. And for those of you who might be less familiar with it, it's just a way of kind of an analogy of thinking about if we've got a stress container that gets filled with stress and we have to carry that around with us all the time, that can be really hard work. And thinking about how we can de-stress or handle our stress in a positive way, as opposed to some of the more potentially unhelpful coping strategies that we might employ. So have a good chat around that. And these first two elements of the training really are about giving language to people. So I've delivered mental health awareness training, you know, all over the country, up and down the country. And what I love is when I go back to a certain setting and people will be using different language. So they'll be saying, oh, my stress container is just really full at the moment, and having conversations about how they might be dealing with that, which is great. And then sort of the second half of the module goes on to look at the place in the system for MECC. So where do we position MECC within our tiers of service delivery? And really, when we think about MECC, these conversations come in our pyramid right down at the bottom. So it's a universal kind of population level approach, if you like. So these are conversations that anyone can have anywhere, and we're trying to encourage as many as possible, and understanding where those conversations then link potentially into higher tiers of service or support. So this MECC for mental health conversation is really that population level approach. And then on one of Nellie's slides, actually, there was a quote that referred to how helpful it was to have a framework. And the framework that Karen brought in for these discussions, these mental health conversations, was the 3 A's framework. And we go through this in quite a bit of detail in module 1 to introduce it. And then as we go through modules 2 and 3, we actually develop those skills and allow people to kind of practice what this language and these conversations look like. So the ask, assist and act is really about getting people's permission to have a conversation, about helping them find support or assistance should they need it, and then planning with the person how they may be able to act on some of this information. That's the broad bones of it. In terms of module 2, so this is really about building skills in module 2, and I guess our aim with the training, whether it's to train the trainer or for the end point user, is for people to, after the training, feel more skilled and more confident to have a better conversation about mental health if we feel that we need to. That kind of was our goal. And so what we want to do is build those skills so people feel more confident. If we have a look at some of the little bits of content from module 2. So again, we bring a focus onto language. So in the top left, you can see those headline articles. So that reference to the cyclist there, that was actually a front page headline in one of the red top newspapers that I found. So that was an actual example of how mental health or mental illness can be stigmatized in the media potentially. And just a reminder that, you know, language can have a real impact in how we perceive people who experience mental illness, and how it can link to fear around people who may experience mental illness. So we go through a few statistics that absolutely show that people with an experience of mental illness are actually incredibly more vulnerable to any kind of abuse or even criminal acts towards them. So we kind of just dispel that. And just a reminder, we actually pick out some specific bits of language that we want to try and challenge or make a change to. We have a think about the barriers to accessing support for people. One of the things that we look at is self-stigma. This can come up in a number of different ways. So maybe it's a case of, my life's okay, what have I got to moan about? You know, there's a lot of people worse off than me. It can show up in terms of oh God, I just need to stop moaning and get on with things, you know. So the way that we speak to ourselves, the way that we perceive ourselves can be a barrier to accessing support. Maybe we perceive ourselves as not the type of person who would access mental health support, or we don't want to have that association. We feel the stigma in society within ourselves, and that stops us. The social stigmas, so we might worry about how friends and family would react if we said that we were going for some support with mental health. Or employers would be another big one, you know, worrying about saying to an employer that we're seeking support for mental illness or mental health support. So yeah, we talked through a number of different barriers, and I think really important to understand those, give people a little bit of time and space to think about what those might be, and also then putting yourself in that, you know, in your professional role, how can we have a conversation that enables someone to potentially access support with those barriers in mind. And a lot of that is about normalizing experiences. And we do talk about in some of the case studies that we use and some of the work that we get people to do on the course, you know, to think about how could we help people address some of these barriers. The language matters. Oh, sorry, Nelly, just the language matters bit. I think I've spoken a little bit about why language is so important, but we also get a focus on positive language. So when we think about mental illness in particular, you know, we don't have a great deal of positive language around things like recovery. And all the statistics and the evidence say that if someone has an experience of mental illness, in all likelihood, they are likely and probable. It's likely and probable that they will make a positive recovery. So I think building this recovery in, you know, we talk about the likeness to a physical health condition. You know, if we were to break a bone and being cast, you know, people don't kind of tell us to get on with things, and you know, we'd be supported through a period of recovery, which is exactly what we're trying to bring into people when they experience mental illness. And then, yeah, so module 3, learning outcomes. So module 3 was based more around where to signpost, what does support look like, where is that end point of the conversation where we might have an example of someone who is open to receiving further support. Where can we get that support? What does that look like? We have a little scenario in this module as well. We call it the Friday at 4 p.m. Scenario. I don't know how many of you, I was lead safeguarding officer for quite a large statutory organisation for a few years, and it was always that phone call at kind of 4 o'clock, 4:30 on a Friday where there was a serious safeguarding concern, and you're thinking, oh, where do I go here? You know, who do I get involved at this time? So that's why and the amount of people who've kind of reflected that to me, like I've actually just seen someone do like a knowing nod on this call. It's like, yeah, that's when it happens, Friday at 4:30 when everyone's just heading home. Darren, thank you. Yeah, we hear it all the time. So we've put the Friday at 4 p.m. scenario in. Like, you know, what does crisis look like for someone if they are in crisis? What do we need to do? So we do think about that. Or what does, you know, sort of that interim support look like for people? So let's have a look at a little bit of content from module 3. So we think about the case study. We do practice a little bit more around language, and then we do quite a bit around signposting. MECC link. I haven't looked at it for quite a while. In some areas, the MECC link websites have a raft of information, and in some areas it's not such good coverage, but it is worth checking out. And MECC link is just one of the places where we ask or recommend that people go to seek further support and signposting opportunities. We talk quite a bit about mental health literacy, so the ability to access and understand and use information around mental health, and that can apply to many areas of clinical work, making sure that we're using language that's understandable, that we are checking, which I'm coming on to, you know, checking understanding. And again, we put a little framework around this. Sometimes it just helps with the memory to lock things in for us. But the check, chunk, check is just a way of saying, you know, am I okay to ask you about something? Chunk it up, so little bits of clear and easy to digest information, and then check the understanding. When we were researching this, Karen shared with me the research that says the average sort of broadsheet, the average newspaper is written in a language that should be at the age of an average 11-year-old being able to read it, and medical information is written in a language that the average 16-year-old should be able to understand. So we actually, you know, we do need to be aware that sometimes medical information or advice can be kind of either lost in translation or not understood particularly clearly. So the check, chunk, check approach is just making sure that when we do ask people if they've understood, rather than just asking the obvious kind of is that okay? So is that all right? Everything okay? And the person just going, yeah, and then walking out and thinking, I don't know what just happened. Actually saying, can you tell me what you've understood from what we've just discussed, so we can make sure that we're on the same page, you know, that kind of approach. And I think throughout the training, what Karen was able to bring is it's so important, the language that we role model and the way in which we have these conversations. And that's a really strong theme throughout the training, is that, you know, it's about having a human to human empathetic conversation. And we've had some really lovely feedback. I'll just share one example that we had, and it was from now. I feel like it was in a GP setting, and we've got a case study in one of the modules, and I think he's called George off the top of my head. Is it George? And we delivered this training. It was one of the first training sessions that we'd done, and the lady that we trained went away and came back for the second of the sessions, and she said, oh, I had a George in clinic this week. And the case study is kind of that you say, he's been recently bereaved, and you're aware of that bereavement, so you just say, you know, we're just checking in with everyone how their mental health and well-being's doing at the minute, and I just wanted to check in with you and see how you're doing. And he was kind of a bit visibly upset, or, you know, and clearly struggling. And no, I'm fine, thank you, yeah, I'm fine. I said, okay, well, you know, we're here if you do ever want to have a chat. And then George had been back in the following week and had actually said, you know, after you asked me how I was, I've been thinking, and I've realised maybe I'm not okay. And they were then able to go on and have a further conversation. So when we talk about MECC for mental health, it really is the subtlety of taking that extra minute or 90 seconds to say, while you're here, we're actually checking in with as many people as possible. I mean, COVID has actually given us a really good frame to do these conversations, because, you know, we've got a lot of people coming through the training saying it's actually, you know, a really nice offer for people to say, we know that the last couple of years have been tough and that everyone's found things difficult in different ways. We're just checking in with everyone. How are you feeling at the moment? Is everything okay? And that's kind of it. And but those drip feeding of conversations is the beauty of MECC across all of the topic areas, isn't it? It's just drip feeding that little, okay, that's fine. If this is something that you do want to talk about, the door's open. So really powerful to hear feedback like that coming through. I think, is that me, Nelly? Is that?
Yes, so we'll stop for a couple of minutes just to check if there are any burning questions while I stop sharing and I share another screen to give you a bit of a demo of the Trainer Hub. Feel free to take on the mic.
Yeah, do if anyone's got any questions in particular. Thank you, everyone. Thank you for your time.
MECC link looks great, but not available in Cheshire and Merseyside. Yeah, that's one of the problems with MECC link. But we do work with trainers during the sessions to explore what they know about services in the local area. So with the lead trainers as well, during the trainer, we can look at refreshing those pathways, so that trainers get delivered something that they can use as well as what they know already. And this is really important because when we talk about cultural competency and cultural sensitive pathways, we need to consider what our communities need, and it's appropriate to them in terms of mental health support. I'm going to, can you see a web page? Don't I have you in my screen? Would you be able to nod if you see that web page? Okay, excellent. That's right. So the Trainer Hub is hosted by the Futures NHS platform, and anyone can have access to this workspace with their email address. They don't have to be part of the NHS to access it. And we just send you an invite, and then you sign up for it. There's a plethora of resources and information in this platform, which trainers can use as much or as little as they want. And I'll show you here, for instance, we have a discussion forum, trainer resources, the training directory, and for instance, I'll show you very quickly the forum. And this is an opportunity for people to explore the wealth of information and support that there is in the wider network. We monitor this, but other trainers do as well, because they get updates from the platform's admin people, and they can answer questions as well. In terms of the training resources, as I said, there's loads of information here that people can use as much as little as they need. For instance, here are the training materials, the online modules. You can use the URLs to embed them in other types of materials, not necessarily those that we provide you with. And as you see, there's one per module, and you can use it in addition or to complement the delivery of your training program. And it all depends on the training needs as well of the group, because some may be very familiar with the MECC approach and may not need so much information about it, have a wealth of experience on mental health awareness, for instance, and again, module 1 can be condensed to that trainer need. I really like the micro learning, and I want to show you one of them. There's a few animations here that can be taken out from the e-learning and the training slides, and can be used as standalone micro learning assets. And I hope you can see. Just checking, can you hear the animation? No. Okay, that's fine. It's, yeah, I was worried about that, but when you are able to look at the information that we send you, we'll make sure that I include one example of the animation, so that you can hear it as well. But it's really nice, and we also used voiceovers from people in the areas as well where we're working, so the accents are from the north of England, for instance. again, I'll go back to the main page. There's a trainer directory as well, so trainers can have a look at who else is in their area. So here you see the people that we have in the pool of trainers across Cheshire and Merseyside. Roberta Pomponio from Active Cheshire and Jan Campbell from Sefton CVS are lead trainers for the region. And then we have quite a few individuals here. And there's, as I say, there's about 100 trainers plus the lead trainers in this pool who you can contact, get in touch with. We also encourage co-delivery of the first session, and during the train the trainer we do try to partner people, and that's proved to be very effective and has improved confidence for delivering the training program as well. And as part of the hub, we also provide information to support trainers' knowledge of mental health and the MECC approach as well. And here you'll see that there is more information that can be accessed. We also have a notice board where we put things that have been just launched. So this was about the menopause training. We ran a train the trainer session, but really anyone who goes through the training program, the core training program, can deliver then the menopause training, and the materials are here as well in the hub. And we also have access and links to some of the things that we have published in our website about MECC, like some case studies. Trainers are also invited to submit case studies that they create for their own audiences. We just check the language and that it's in line with the content, and that way we assure the trainer and their organization's delivery. And so I'll stop it there because we only have 1 minute before we commence with the Q&As. And I will finally just share how to access the offer, the training offer. And I'll share my screen with the slides again. Sorry, I will have to. There we are. Sorry, it was in an odd place. How to apply? So to nominate lead trainers and trainers, organizations must provide with a letter or email of support to the individual and ask them to complete an application form. There's a document with detailed information about the expectations, about the benefits, and about the support that's going to be available to the individuals and the organizations through this program. And I will post it through the chat in a minute. And if you have any questions, I would like to discuss your training needs, your ideas with me, I would be very happy to have a one-to-one meeting with you at a convenient time in the next few weeks. Ideally, we want to recruit everyone by the 9th of September. And we are assigning places on a first come, first basis, providing they fulfill all the criteria in terms of training skills, for instance, for lead trainers, and their interest as well. And so I'll stop there and I'll open up to questions. I'll stop sharing.
There's just one question in the chat, Nelly, about if funding is going to be made available to roll out.
Nationally, we are in the process of discussing opportunities with Health Education England in other areas. and we would also be looking for opportunities wider as well. So at the moment, there's no confirmed funding for a national rollout or a region outside the Northwest just yet. But there are very positive noises, so hopefully we'll be able to offer something very soon. Post, it's in the chat.
Yeah, there's a question about it saying, is a certificate in training enough to meet the criteria?
Yes. For the training role, the trainer role, that's absolutely fine. A little bit of experience on delivering training, it's always useful, but there is practice in the trainer, doesn't it, Dawn, which builds confidence, especially for those that haven't delivered training or facilitated sessions for a while. We've had a variety of people with different backgrounds, so we try to provide during the trainer with opportunities that fit and respond to training needs. Sorry, I don't know, I can't find a way of posting the document.
Nelly, we can email the document out to all the participants if you send me anything that you need to send out.
Will do. I'm sorry.
And if you copy Laura in, because I'm on leave from lunchtime
Okay.
today, so we can make sure that goes out.
Okay. So any interest from organizations here exploring? Raise your hand, don't need to talk. Just so we can, yeah, excellent. That's great. Some various notes. Excellent. That's lovely. Thank you. So, well, we'll be very happy to talk to you any more that we have done just now, and to look at how this may fit within your work and your initiatives, your projects. And so very much we are very thankful for your support and your time today. So we'll stop the session now, and we look forward to hearing from you in the near future.
Thanks very much, Nelly. We will be posting the recording on our website, on the CHAMPS website. So if colleagues haven't been able to attend, they can see that. And we'll also have a news item based on the information you sent out yesterday, Nelly, about the expressions of interest in the offer. So hopefully anybody who's not been able to come today, we can get the message out there.
Just one thing is very important I didn't mention during the presentation before you go. There's a training grant for lead trainers and trainers. For lead trainers, it's £1,000 and it's paid to the organization that is hosting the lead trainer. And for trainers, it's £200. And again, it's paid to the organization hosting the trainer. And it's really to support some of the time that they're going to be using with the project and getting trained. So in addition of the training, we're providing this training grant to organizations to support their time. And it's claimable when they have delivered the first training session. And it's very much about supporting and incentivizing as well organizations, because we know that capacity can be very, very tight at the moment with COVID pandemic and all of the other things that are happening across the health system. Okay, well, thank you very much, everyone.
Thank you.
Thank you very much, Nelly and Dawn. Thanks a lot, everybody, for coming.
Bye-bye.
Bye.